University Medical Center. And also, my assistant and program manager here at the center, Christy, told me to tell you all I'm tall, dark, and handsome, despite this picture. So, at any rate, so let's get going, and I'll get us started. And give me just 1 second here to get the slides up. And here we go. Okay, good. All right, so I've entitled this presentation as New Data on the Geography and the Contributions of Primary Care Nurse Practitioners. Here you can see our website that I noted a little bit earlier. A little, okay. All right. Sorry, I just was hearing some echoes here and just checking that out. Okie doke. So, all right. There we go. Trying to figure out. I think we're there. Okay. So, I'm going to talk about very briefly results from 3 recent studies that we've done. And none of these studies specifically sought to identify rural nurse practitioners and do great analysis of these particular nurse practitioners in these rural areas. However, that will be where Sue comes in, where her focus will be specifically on rural nurse practitioners. It turns out, though, in the 3 studies that I'm going to briefly review, we run into these rural areas and we run into nurse practitioners in these areas. And so I'm going to be talking about that. And very briefly, so I'm not going to go into much detail at all about data or methods, just quickly set up the study, show you the results, and move on. And these studies will be one about planning for the Affordable Care Act's insurance expansion. And here our goal is to identify the gaps in the country where we will see primary care physician capacity not perhaps up to par to what we think the needs will be for newly insured people. And you'll see this in just a moment. Then we'll talk a little bit about other studies that we've done that use Medicare claims data that identify primary care nurse practitioners and primary care physicians. And we do a series of comparative analyses around the types, the quantities, the costs of these services provided by both NPs and physicians. We also look at where are NPs practicing in the country. Finally, I'll end up with a few slides that just summarize some of our findings of a national survey of primary care nurse practitioners and primary care physicians that we conducted about almost 2 years ago, and that'll provide further context. Then we'll set up for Sue. Okay, I want to acknowledge my research teams, and there's too many people to pull out and discuss. I'll just indicate that most of this work comes from the team that is listed number 4, assessing the contributions of nurse practitioners. So that would be Jennifer Perlis at Brandeis University, Karen Donnellan at Mass General Hospital, Kate DeRoche at Mathematica, and Bob Dittis at Vanderbilt, Lisa Iazzoni at MGH, and finally John Graves at Vanderbilt is also helping out or providing work on this analysis as well. I want to disclose that I'm funded by the Johnson & Johnson Campaign for Nursing's Future, the Gordon and Betty Moore Foundation, the Robert Wood Johnson Foundation, and the State Health Access Reform Evaluation Program, the SHARE program. And finally, just to disclose, what I'm going to be presenting are my views and our data. These are do not reflect the views of the National Healthcare Workforce Commission, which remains unfunded. Now, so many of you may know about the commission. It was included in the Affordable Care Act when it was passed in 2010. The idea of the commission would be to have a group of anywhere of 10 to 20 health workforce analysts um, working together with the payment policy generated from the Medicare Prospective Payment Assessment Commission and the folks at MACMAC for the for Medicaid insurance, so that we would be hopefully a integration of workforce policy with Medicare payment and Medicaid access policy. However, the Commission has to be funded by Congress by law, and we've not been able to get the Commission passed, funded by Congress. So it's still unfunded. If you're interested in reading more about it, you can see this reference. And who knows, with the recent midterm elections, we may see some change forthcoming. All right, so let's get on with things. And the first brief study I want to discuss is around the planning for the Affordable Care Act's insurance expansions, and to see if we could identify gaps in primary care physician capacity. So you can see our objectives. We were to see where do we expect growth in the country due to the insurance expansions, i.e. the Medicaid enrollment and the state exchanges. And then once we see where we think there will be growth in the insured populations, assess to identify what's the capacity of the primary care workforce in those populations. And again, not going to show you data or a lot about the analysis. This is a paper that's under journal review. So instead, I'm just going to go through a couple of slides that show the results. So when we do this analysis, you see that 17% of the expansion population resides in what we see as a low primary care physician capacity area. And that's compared to the current situation where we have 13% of the U.S. population, or roughly 55 million or so folks who have inadequate access to primary care. As you'll see in a map that I'll show in a moment, these potential capacity gaps in primary care physicians are identified in nearly every state. And in point 3, I won't read this, but you can take a look and see where we see the large Medicaid eligibility population, mostly occurring in the Deep South and some of the Appalachian areas, and the marketplace, the state exchanges, that will hit different parts of the country, the Western Mountain, the Upper Plains states, parts of Florida, and in Texas. And this map shows just sort of what I was saying, the Medicaid expansions being more in the Appalachia, Deep South areas, parts of Texas and New Mexico, and the insurance exchanges hitting primarily, these are the darker blue areas, more in the Western Mountain states and elsewhere in the country, particularly Florida. But if you look at the whole nation, there's I don't know that there's any state that won't have some area, some county that will be challenged. The primary care workforce will not be challenged. This slide is a little complicated, but I like it because I think it tells an interesting picture. And let's first take a look at, I hope you can see my cursor, but I'm over here on the left part of the figure, and you see these counties, metro areas of 1 million population or more. Now just sort of let your eye drift down and follow to the bottom of that. And what we hear is that at the top of the figure are areas with high population, and as you go down, you see areas of the country with fewer population. That's point 1. Then over into the body of the figure are these 3 big columns: accessible primary care physicians, accessible nurse practitioners, and accessible physician's assistants. And then we color code them with sort of a dark purple for physicians, the orange for NPs, and the green for PAs. And you can see as a national average of 88.8 primary care physicians per 100,000 population. And so a large number of physicians, and compared to only 9.8 NPs per 100,000, even fewer physician assistants. But as we then kind of move down the slide, and as you see the population areas, the number of the primary care physicians per population increases to 90.6, then gradually falls as we get into lower and lower populations, so that we see that the physicians in primary care seem to be clustering higher numbers per population in the high population areas, and that falls as we get to lower areas. Now, there's still a large number of physicians in these very sparsely populated areas. We're down to 72.8. Now, if we look at the nurse practitioners, again, a smaller number relative to physicians, but as we get into the lower populated areas, we see a different phenomenon, where we actually see more NPs. The rate of NPs per 100,000 population is increasing. So it suggests that in these lower population areas, we'll see more NPs than when we do in these areas of high population, just opposite of physicians. But it's still a small number. It's 15.8 relative to 72.8 for physicians. The PAs don't really see a clear trend here. Now, one other result is, as we were looking at these data, the data revealed that the areas that are going to be most impacted by the primary care, or by the expansion of insurance, will be in areas where there are the most restrictive scope of practice laws governing nurse practitioners. And you can see this with this next slide. Let's look at the states at the bottom, full practice, where NPs have full autonomy. And you can see that 63% of the population resides in the 63% of the full capacity practice states are in areas where there's a high capacity of the primary care workforce. Where in the states that are classified with restrictive practice, you have far fewer of the population, a third of the population, are in high practice states. You have 19% of people who are in low capacity county areas. So the point here is, in restricted practice states, you have a much greater concentration of people in the moderate and the low capacity areas relative to the full practice areas. So the implications of this first part of this first study is that addressing gaps in the capacity of the primary care physician workforce, it seems to us, are going to require the increased use of nurse practitioners, physicians, and others on the team. And if we were, as a policy, to remove these scope of practice restrictions and allow more states to be full practice states, this would have meaningful effects. It would increase the access to health care for millions of Americans. And it would occur even more as we see more NPs move into those areas that are currently restricted. But in the end, we don't think that this will fully resolve all the access problems, because we still have a relatively smaller number of NPs compared to physicians. I do want to just sort of break in and say I really apologize. I'm not giving the most precise presentation, but I am severely distracted by a jackhammer outside, and I can hardly hear myself think or talk, so I apologize, and I hope it's not coming through too much on over the airways here. Sue, I hope you don't have that problem coming up. Anyways, so speaking of nurse practitioners, I want to briefly talk about a second study where we are using Medicare claims data to analyze primary care nurse practitioners and primary care physicians providing care to Medicare beneficiaries. These are the questions that we wanted to ask of the Medicare data, and we wanted to figure out how many NPs are billing Medicare, where are they located in the country, are there differences in the overall provision of primary care services between NPs and physicians, and then do the beneficiaries that seek care from an MD or an NP, do they differ? And this study was published in the journal Nursing Outlook, and you can take a look at that for those of you who want more information. Now, when we did this study, we had data on Medicare beneficiaries for 2008. Our team now has more current data. We have 2010 data, and we're looking to get data up through 2012, but that yet is not yet in. But when we did this analysis, we had the 2008, we were able to identify 45,000 nurse practitioners who were using their own national provider indicator number to bill Medicare. When we looked at where they were practicing in the country, we see that the states with the gray, the black, and the red, these are the states where we saw the highest rate of NPs, nurse practitioners, billing Medicare per 1,000 Medicare beneficiaries. And further, though it's not shown on this slide, primary care nurse practitioners are significantly more likely than primary care physicians to practice in a federally designated health professional shortage area. And primary care nurse practitioners were also more likely to practice in rural counties compared with primary care physicians, although the difference here between the two groups we felt was not large, it was more modest. Now, what are the services that are being billed for by primary care nurse practitioners and physicians? And again, this is a sample of Medicare beneficiaries. Both doctors and NPs the majority are billing for evaluation and management services, and you can see those listed at the bottom of the slide: office visits, hospital visits, emergency and home visits, and nursing home visits, those kinds of things. Now, the primary care nurse practitioners, about 9% of their claims go for procedures versus 4.6 billing for physicians. The imaging studies, doctors doing more of that, getting more payments for imaging studies than our nurse practitioners. And the nurse practitioners, their payments are lower, 4.8% of their payments are for tests versus 5.8% for physicians. Now, what about the types of beneficiaries or patients seen by these two groups of clinicians? And nurse practitioners overall are seeing a slightly younger age beneficiary, more likely to be female, more likely to be black, more likely to be Native Americans compared to physicians. And I think the most important slide out of that study is this one that talks about really what we've done is we've said, all right, a Medicare beneficiary can qualify for Medicare in 3 different ways. By age, 65, they qualify in, or by having certain disabilities, or they're duly eligible for both Medicare and Medicaid, which is really a proxy for very severe poverty. And when we look at this, the beneficiaries and how they qualify, we see that by age, the nurse practitioners, fewer of them, 69% of the beneficiaries treated by the MPs, qualified as a result of age, where it was 3/4, 75% for physicians. Next, disability, 30% of the beneficiaries seen by NPs qualified as a result of a disability versus 24% for physicians. And on the dual eligibility, here, 40% of the NPs that beneficiaries seen by NPs qualified as a result of dual eligibility compared to 27%. So NPs taking care of more disability and more dually eligible patients. Now I'm going to finish up with just a few more slides, and we'll turn it over to Sue. And this comes, the third study was one that we conducted. It was a national survey of primary care nurse practitioners and physicians. The study I just talked about were only of NPs and physicians taking care of Medicare beneficiaries. This is a survey of all NPs and physicians. We published this study, parts of this anyway, some of the main results were published in May in the New England Journal of Medicine. This is May 2013, and you can see that study here. And another part of the study is just recently made available on the journal Nursing Outlook. So if you have access to that journal, you can find it online. It will be published in hard copy soon. And a third article on a different set of issues coming from this survey will be published in the medical journal soon. So what I want to briefly indicate is that the practice characteristics of physicians and nurse practitioners. So this is the whole sample of physicians, 505, and 467 nurse practitioners. And when we looked at this, this is poorly worded, this first one, work in MD, NP, co-practice. What I'm really trying to get at is we're asking physicians, are there nurse practitioners working with you in your office setting or practice setting? And 41% of physicians said yes, NPs work with them. Where NPs, it's 81%, double that number, that my practice, it's working with physicians. And as you can see below that, nurse practitioners work about 10 hours less on average per week and see about 20 patients fewer in a typical week than do physicians. When you look at the practice settings, physicians tend to be concentrated in the ambulatory settings, somewhat in the other settings, whereas NPs are more distributed in the other settings. And you can think of the other settings as churches, prisons, school health, university health, lots of different areas. With regard to revenue, NPs are more likely to report getting their revenue from Medicaid, less of their revenue from private insurers, and from other sources, which we don't have time to talk about. And then in terms of the patients served by physicians and NPs, you can see that nurse practitioners more likely to be taking care of, or 25% or more of the patients that they take care of are African American or Black, Hispanic or Latino, more likely to have a primary language that is not English, and far more likely to be taking care of patients who are uninsured or no insurance coverage. Location, NP is more likely to be in rural areas and in urban areas relative to physicians. Now, there's a lot of information that you can look at in the Nursing Outlook article. We break the characteristics into these 4 columns, and there's lots of information for those of you who might be interested. But let me just sort of summarize some of the key, take-home points, and I'm just going to not even show these here because I think we're running out of time. But I think the overall take-home points from these 3 studies is that there's a significant opportunity to expand access to primary care by using primary care nurse practitioners, and by that, as well as primary or physicians assistants. This is especially a big opportunity for rural areas of the country and in the low-capacity areas that are experiencing the expansions of newly insured populations. A real, target-rich opportunity. The scope of practice restrictions are indeed a barrier, but when we asked NPs in these surveys to talk about the challenges, many of them said the challenges are really at the local hospital and medical society rules and regulations, and not so much at the state scope of practice. Finally, because most primary care nurse practitioners work with physicians, it is unlikely that we would see dramatic increases in competition of NPs and primary care physicians. And this is something that a lot of physicians have told us in our survey that they so it doesn't look like that fear would be substantiated. I've, I think, taken enough time, and what I'd like to do now is transition over to Sue Skillman, and I want to briefly introduce Sue, and Sue will get us going. So Sue is an investigator at the WWAMI Rural Health Research Center and is also the Deputy Director of the University of Washington Center for Workforce Studies. She is a nationally recognized expert in health workforce research and policy. She has great expertise in policy analysis, conducted many surveys, and a lot of secondary analysis of secondary database. Sue is working on an evaluation of a technical assistance program for rural physician training tracks. She is chair of a U.S. delegation to the International Medical Workforce Collaborative. She's a member of the advisory board for the Washington State Centers of Excellence in Allied Health, a member of the National Organization of Offices of State Rural Health Workforce Committees, and it just goes on and on. And so rather than take up any more time, let me turn over the microphone to Sue, and then be sure to send in your questions.
Great, thanks, Peter.
Okay.
Somewhere is a thing I'm supposed to, oh, there we go, look at that. Okay. All right, can you see my screen?
Yes,
yes.
we can.
Great. Oh, that was easy. All right. Well, first of all, I don't have a jackhammer outside the window, but I am getting over a bad cold. So I may need to take a break at some point here, or if I have to really take a break, Holly Andrilla from the center is here and will take over in an emergency with going through the slides. She also volunteered to pretend to be a jackhammer if we wanted to even things out. We'll proceed and presume we don't need that. So anyway, as Peter said, I'm with the University of Washington Rural Health Research Center, also with the Center for Health Workforce Studies here and our AHEC. And I'm going to also share results from 3 recent studies of rural nurse practitioners. And these studies were all conducted through the University of Washington Rural Health Research Center. Okay, and now we have to, there we go, okay. We are one of 6 rural health research centers around the country funded by HRSA's Office of Rural Health. And I probably don't need to go through too much background, but just to recap, because Peter set the stage nicely, we know that rural health workforce shortages exist, and encouraging more nurse practitioners to work in rural areas is frequently cited as the solution. However, we really don't know a huge amount about rural practicing NPs, what causes NPs to practice in rural areas, and the extent to which NP education is preparing NPs for rural practice. These are the 3 studies from which I'm going to share findings. First, I'll share some recent findings from our current analyses of the national sample survey of NPs that HRSA conducted in 2012. The other 2 involve analyses of surveys that we at the University of Washington's Rural Health Research Center conducted, one in 2011 and 12 of rural primary care physicians, nurse practitioners, and physician assistants, and the other was a survey of all U.S. colleges with NP education programs. For the NSS-NP analyses, I want to acknowledge the others on the team, and they are Holly Andrilla from the University of Washington and Joanne Spetz from the University of California, San Francisco. The National Sample Survey of NPs was a survey of a sample of all licensed NPs in the nation, as I'm sure many of you know. It had a 60% response rate and includes responses from about 13,000 NPs. We used in this and in the rest of our studies the rural-urban commuting area, or RUCA taxonomy, the zip code version of that, to define rural and urban areas. Our analyses from the NSSNP found 86% of all NPs to be located in urban areas of the country and 14% in rural areas. And as an aside, it was very reassuring to find that these numbers were similar to another study we conducted using 2010 National Provider Identifier, or NPI data. In that study, we found 85% of NPs with NPIs to be urban and 15% to be rural. Among these NPs in the NSSNP data set, we also found that more rural than urban NPs were working in a position that required their NP credential. You can see there 90% of rural versus 86% of urban. So the subsequent analyses from the sample survey that I'm going to show you focus on these NPs, the ones who are working in jobs that require an NP credential. As you can see from this slide, we found rural NPs compared with urban were slightly older, 49 years compared to 48, were composed of more males, and were less racially and ethnically diverse compared to their urban counterparts. Rural NPs were slightly older when they completed their initial NP education, 38 versus 36 years. And more rural NPs became an NP through a certificate program than urban NPs, although the vast majority of both urban and rural NPs enter the NP profession via a master's program. Excuse me. We found that rural NPs were more likely to be in family practice compared with urban NPs, and that's shown in the figure to the left. And on the right, you can see that nearly 70% of rural NPs, among those practicing using their NP credential, were in primary care. This difference is not terribly surprising. We know that there are a lot more opportunities to practice as a specialist in urban areas than there are in rural areas. So now focusing on the primary care NPs, from our analyses we found that more rural NPs work full-time, 74% compared with 68% in urban, and more billed using their own NPI number. Salaries, however, were not significantly different between urban and rural, but these salaries have not been adjusted in any way for cost of living, and we suspect that those rural salaries might look higher after being adjusted, and that's something on our to-do list. Other things we've looked into so far in our analyses are shown here. Rural primary care NPs were less likely to have a physician on site the majority of the time they practice compared with urban primary care NPs, and rural and urban NPs appeared to take similar amounts of weekend and evening call. But rural NPs were more likely to have a personal DEA number for prescribing compared with urban primary care NPs. Finally, rural and urban primary care NPs reported similar levels of satisfaction. More than 90% of both were satisfied. These analyses are still in progress, and we'll soon be reporting more about NPs in different types of rural practice, as well as more details about urban NPs in general. Okay, on to the second study. This is from our survey of rural primary care physicians, NPs, and PAs. We've published one paper out of these analyses, cited on here, and I want to be sure to acknowledge the co-authors. They include Louise Kaplan of St. Martin's University and Holly Andrilla here from the University of Washington Rural Health Research Center, and Mark Dosher, who at the time was director of the University of Washington RHRC. A few background details about this survey. We chose 13 states across the U.S. where we could obtain licensure data with enough detail and at sufficiently low cost to provide a sampling frame. Our response rate was just 30% overall, or 40% for NPs, which we know isn't a great number. But because we were not always able to distinguish primary care providers from specialists in our initial sample, we suspect the response from primary care providers was actually higher than what is shown by this response rate. Of course, you just have to take our word for that or go along with our hunch. The goal of this survey was to estimate outpatient productivity and scope of services provided by the three provider types. And this map shows the 13 states in our survey. They're in green. We selected them for their overall national distribution. You can see we have some in all census regions, as well as to include states with each of the three general categories of NP practice laws. And I'll talk more about that in a minute. Excuse me. First, our analyses comparing rural primary care physicians, PAs, and NPs found that NPs provided fewer average weekly visits than other provider types, 64 a week compared with 78 for PAs and 85 for physicians. And that's consistent with them working fewer hours than the other provider types. More of the practice differences among these three provider types can be seen in that medical care article that has been published. As I mentioned, we also examined differences among rural NPs and states with the three categories of practice authority. 6 of our study states, and those are the ones that are the lightest blue, were ones where NPs had full practice authority. 2 states required physician collaboration, which we've called reduced practice states, and that's that middle color of blue. And 5 states required physician supervision and or delegated prescriptive authority, and we call those the restrictive practice states, and those are the darkest colored states. Across all state practice authority categories, most rural NPs worked in practices associated with physicians. I think that's a finding we're seeing in numerous studies. And slightly fewer of the NPs in full practice authority states had physicians associated with their practices, but they still all mostly had physicians associated with them. Okay, rural NPs, and just a reminder again, the survey looked only at rural. So rural NPs provided similar average weekly numbers of prenatal care visits. Those are the 3 bars on the far left. And in this case, the full practice states are the light blue, again, reduced practice, the middle, and restricted practice, the dark blue. So rural NPs provided similar average weekly numbers of prenatal care visits and minor procedures across the types of state practice authority. Oh, am I on the wrong slide? Okay, thank you, Holly. I'm glad you're here. Let's see. There we go. I have to get to the next one. Okay. Once again, rural NPs across the 3 types of state practice categories provided similar weekly numbers of prenatal visits and minor procedures. But to the right, that set of bars shows that NPs in full practice states delivered about 1/3 fewer well child visits. Okay. That's because, did I give the data on that previous one? No, I didn't. Okay. That's because it was missing on my note slides. So here we have the weekly visits, and NPs in full practice states provided 18 to 23% fewer weekly visits than in other states. Okay, even though the rural NPs across the 3 types of states provided similar mean numbers of weekly hours. Okay, we'll get back on track. Rural NPs in full practice states, that's the bar on the left, though, took about 1/3 more call than NPs in reduced practice and restricted practice states. Okay, on to the 3rd study. Excuse me. Now I'm going to quickly summarize these. It's from a survey of NP education programs in colleges of nursing across the U.S. To assess the level of attention they paid to educating nurse practitioners for rural practice. And co-authors for this study included Louise Kaplan at St. Martin's University, Holly Andrilla, Stephanie Ostergaard, and Davis Patterson, all of the University of Washington Rural Health Research Center. Our study goals are listed here. We asked these colleges, these NP programs colleges, about many of the factors presumed to be associated with encouraging rural practice, although most of the evidence linking these factors with rural practice comes from studies of physicians. But we we used that evidence and kind of proceeded with that for the NPs. We contacted all 354 colleges with NP education programs across the country, and we're really happy to get a 74% response rate. Nearly 2/3 of our respondents said that it was very important to the college or program's mission and goals to prepare NPs for practice in rural areas. That's that first bar. 31% of the schools indicated it was somewhat important, and 8% reported it was not important to their mission or goals. So for the rest of my presentation here, we refer to the schools that said educating for rural practice is very important as the rural-oriented NP schools. Not surprising to us, we found that more of the rural-oriented colleges were located in the West, and of course, you know, much of the West is rural. Conversely, fewer of the colleges with NP programs in the Northeast were rural-oriented by our definition. In this slide, the responses of the rural-oriented colleges are shown as the darker blue bars. We found that compared with less rural-oriented colleges, much higher percentages of the rural-oriented ones reported that they actively recruited students from rural areas. So that's the pair of bars to the left. Much higher percentages of rural-oriented colleges reported that they actively recruit students who intend to practice in rural areas, and that's the middle set of bars. And higher percentages of rural-oriented colleges reported that they consider rural residents among their admissions criteria. These bars represent responses to questions about barriers to promoting rural NP practice. The dark blue bars show the percent who responded. I should say that the denominator here are just the rural-oriented NP colleges. So the dark blue bars show the percent who responded that the factor was a major barrier to rural student recruitment and training. Medium blue, minor barrier, light blue, not a barrier. A third of the respondents, and these are the top bars here, indicated that a major barrier is that potential rural students find it difficult to relocate or commute to campus-based programs. The limited number of clinical training sites in rural areas was cited as a major barrier by more than a quarter of rural-oriented colleges, and that's the second set of bars. And about 1/5 of the rural-oriented colleges reported the expense to students was a major barrier to promoting rural NP practice. And I won't go through all the rest of these. We included a number of questions about teaching methods. Here are a couple of the key findings. More rural-oriented colleges taught using only distance learning methods, and most of the rural-oriented ones use a hybrid mix of distance and in-person approaches. The majority of rural-oriented colleges, 89%, had clinical training sites. So in general, we found that the rural-oriented colleges with NP programs walked the talk of prioritizing education to prepare NPs for rural practice. So just a couple things in summary, I'll go through really quickly. 14 to 15% of NPs working in NP roles in the U.S. worked in rural areas. By comparison, about 20% of the U.S. population lives in rural areas. More rural NPs work in positions that require their NP credentials than do urban NPs. Nearly 70% of the rural ones worked in primary care. More work full-time, billed using their own NPI number, had a DEA number, and rural care, primary care NPs were similarly satisfied as were their urban counterparts. Rural primary care NP practices appear to be affected by state practice laws, while NPs in states with full practice authority had fewer weekly visits. They did take more calls, so there's something different going on in those states, it appears. The majority of colleges with NP education programs indicated that educating NPs for rural practice was a priority, and these schools seem to be using strategies that may in fact work to accomplish that. But we don't really know. We need to know more. Here's the classic more research is needed slide. What attracts the NPs to rural practice? We'd like to know more about that. Is it being from a rural area? Is it scholarships, loan repayment? Is it education, having education opportunities in rural areas? Salaries, practice, or business characteristics being different? Distance education may reduce barriers posed to the rural students, and there's always the issue of clinical training. It's tight for all health occupations, and securing new rural clinical training opportunities could be a rate-limiting factor for growing the rural NP supply. Further research is needed to evaluate the effectiveness of approaches used to promote NP rural practice, and wouldn't it be nice to have an NP master file like the AMA physician master file, where we could actually connect the dots between where NPs are practicing and where they went to school and other factors. But we don't have that, so hopefully we can keep working on these research questions into the future. So back over to Christy and Peter.
All right, Sue, thank you very much. And I think had I been able to foresee this hour, I would have just introduced you and listened to you all this way instead of trying to compete with a jackhammer on my end, which was a little unnerving. But be that as it may, I think we have just a couple minutes for a couple of questions. And I'm going to ask Christy Friedman, who you know now is the program director for the Center for Interdisciplinary Workforce Studies here at Vanderbilt. Christy, I think we've got some questions, right?
We do. We have a couple. The first one, we have a big issue with legislation trying to restrict NPs further in our state. Can I get a copy of this presentation?
I'm happy to forward a manuscript that I showed you about the analysis of Medicare claims data. That one is easy enough to do. The other are a presentation that I was started with around the geography of the primary care workforce. Unfortunately, that information is all under a journal review, and I can't make that available at this time. But I would be happy to do that later on when I can. Sue, are you able to make anything available on your end?
We'll update the slides and make them available to Christy. I don't think there's anything there that we can't share.
Okay, great. And we'll get those posted up onto the website. So if anyone's looking for those, they can either contact me by email directly, or we can put them up there as well. Okay, we have another question. Were you able to examine the availability of psychiatric NPs in rural settings? Peter?
Sue, I'm not.
Or Sue?
I think that might be for you, Sue.
Yeah, I mean, I think that we can identify psychiatric NPs in the National Sample Survey. We haven't done anything with that yet, but that's a good question to add to the to-do list.
Okay, great. Okay, we have one more for both Peter and Sue. How did you determine what NPs are practicing in primary care?
Sue, do you want to go first, or shall I start?
Well, I can dispense, I think, fairly quickly. It depends on which survey we're talking about. With the National Sample Survey of NPs, on the slide, I put a little footnote that indicated which specialties we included as primary care, and we did that pretty much mirroring what HRSA had already done in their analyses. So there's certain specialties. On our survey of the 13 states, we actually asked the providers if they were, if they were doing primary care, basically. So they had to, we narrowed down by specialty to some extent where we could, but then ultimately they had to opt in by saying yes to that question.
On that same question, it also varied by the study. So for the national survey, we relied on the reports of the NPs' education and their work setting, and we did a lot of double checking